natin ang bagyo. Lumayo ko yung banda natin.
Hello, hello.
Good afternoon, sir.
Good
Sir,
afternoon.
you can start. Sir, you can start, sir.
Thank you, sir. I'll just share my slides, sir. Just a minute.
Yes, sir. Your slide is visible, sir.
I'm audible, sir. Am I audible?
Hello.
Am I audible, sir? Uh, am
Yes,
I
sir.
audible? Yeah, am I
Yes, sir.
audible?
You are audible. You are audible, and sir, your slide is visible.
Okay, so should I start,
Oh.
sir?
Yes, sir. Yes, you can, sir.
Yeah. A very good afternoon. I'm Dr. Samir Gulati. Yeah. Yes, sir. So at the outset, I'm very thankful to the organizers to give me this opportunity to present today's topic, that is hypokalemia. Now, hypokalemia is a very important and a pertinent topic, which is like relevant to our everyday ward practice, wherein many of our admitted patients can be having hypokalemia. The reasons for hypokalemia can be very diverse. It might just be the transcellular shifts. It might be just because of the transcellular shifts that happens in our sick patients who are on a number of medications that can lead to this shift, or they might also have certain drugs which can cause them to lose potassium through the urine, or even they may be presented with very common manifestations such as nausea, vomiting, diarrhea, which can also contribute to the hypokalemia. Now, it is we should have a very high index of suspicion to think about hypokalemia at the time of the clinical presentation of the patient because of its obvious management implications. We will go through the clinical presentations, the investigations, the various histories that we can elicit from these patients, and then the nuances of the treatment in the coming few moments. Now, to begin with, we all know that not only potassium, but along with potassium, magnesium, phosphate, and protein, all of them are intracellular, and the counterparts in the extracellular fluid are sodium, calcium, chloride, and bicarbonate. Now, there is a these cations and anions almost balance each other and maintain the not only the osmolality but neutrality, but also the electrical neutrality in the cell between the intracellular and extracellular spaces. Now, maintaining of this osmolality and the electrical neutral ship is very important because of the various like physiological mechanisms that run in our body. They are dependent upon this very purpose of the equal osmolarity and like electrical component across the cell membrane. So if one like element, potassium or anything else, goes from one space to the other, it will affect the counterpart electrolyte as well. Now, what can be the clinical manifestations of hypokalemia? Well, having understood that what is potassium doing in the intercellular spaces, uh, it is but obvious for us to think that these like the clinical manifestations uh, can range from the muscular manifestations, from the ECG arrhythmia manifestations, and most commonly the presentation will range between these two clinical like components. And a very important part for us to understand is that the severity of the manifestations will tend to be proportionate to the degree and duration of hypokalemia. What do we mean by this is that what is the amount of hypokalemia that is present in a given patient, and how rapidly that develops decides how severe the manifestations will be. For instance, it is well known that that the severity of presentations will be more if the hypokalemia ranges from 2.5 to 3 milliequivalent per liter. However, if the drop in the potassium level occurs very fast, then the severe manifestations may be seen even with a potassium level of maybe 3.2. So it's not that there is one absolute value of potassium which will explain the severity of presentation. The equally important part may be how rapidly that fall has happened. But usually, as a norm, the symptoms generally do not become manifest until the serum potassium is below 3 milliequivalents per liter. So this present slide is showing the 4 prominent clinical manifestations of hypokalemia. And you will observe that other than the severe muscle weakness, the other components are by and large primarily belong to the laboratory evaluation. And hence, that's why I said that keeping a very high index of suspicion is very important. Identifying the clinical scenarios which are liable to like lead to hypokalemia with maybe subtle muscle weakness should be good enough for an astute physician to think that my given patient can have hypokalemia, and then to order his investigations and follow up the patients accordingly. What can be the clinical scenarios in which hypokalemia can occur? Well, as I said, and as we will see, the most prominent cause is the intracellular shifts. So a critically ill patient who is being nebulized, is on drugs such as beta-1 agonist receptors, is running fever, and all of these scenarios, or is on diuretics. So these scenarios are typically seen with hypokalemia. So any one of those patients, if they present with even subtle muscle weakness, you should think about a possibility of hypokalemia. So other than severe muscle weakness, the other important causes are cardiac arrhythmias and ECG abnormalities. There are certain kidney abnormalities, and even these patients can have glucose intolerance, by and large because due to the reduced insulin secretion. Now, coming to the severe muscle weakness, usually these patients, if they have muscle weakness and if they have severe hypokalemia, or if that hypokalemia develops rapidly, then these patients can present with muscular weakness, which usually starts from the lower limbs and then can progress to involve the trunks and the upper limbs. Now, again, this muscle weakness will usually not occur at serum potassium concentrations above 2.5 milliequivalents per liter. That is, if the hypokalemia develops slowly. However, if the hypokalemia develops rapidly, then the muscle weakness can be appreciated even with higher serum potassium concentration. This is what we have been repeating again and again, that the rapidity of development of the potassium levels can also decide whether a particular patient will have severe symptoms or not. Having said that, the weakness in thyrotoxic periodic paralysis can occur even at higher levels. So maybe levels such as 3.2 milliequivalents per liter. A person who's having thyrotoxic periodic paralysis can present with muscle weakness. Now, muscle cramps, rhabdomyolysis, and myoglobinuria will also occur with potassium concentration less than 2.5 millicoulomb per liter. Now, I would like to explain the fact that in our body, the potassium plays a protective role when a person is exercising. And why do I say this is because when the person exercises, the release of potassium will cause vasodilatation and will improve the circulation of the muscle, and hence the person can exercise without any complications thereof. If potassium is less, then this vasodilatation and the blood supply to the muscles is compromised, and this compromised perfusion of the muscles can then lead to muscle cramps, rhabdomyolysis, and myoglobinuria. So hence, lower potassium person who have lower potassium levels may have this serious complication. Now, this fact of rhabdomyolysis in patients of hypokalemia will bear very important implications in the treatment aspect also, and we will review this in the slides when we will be discussing about the treatment aspect. When we're talking about muscle weakness, then the other involuntary muscles such as respiratory muscles, the GI muscles, both the small bowel and the large bowel can get compromised and can lead to respiratory muscle weakness and bowel dilatation, nausea, vomiting, pain abdomen, even something like a colonic pseudo obstruction, which is better known as Ogilvie syndrome. So there is a wide-based manifestation in the body because of hypokalemia, and ranging from our muscles of the extremities as far, and also the involuntary muscles of the respiratory system or the of the gut. A very serious problem encountered in patients of hypokalemias are cardiac arrhythmias, and this is what can also lead to mortality, and this is what makes the identification and management of hypokalemia very important in our patients. And it has been seen that all types of arrhythmias can be seen in patients with hypokalemia, ranging from preatrial complexes to premature ventricle beats, sinus bradycardia, paroxysmal atrial or junctional tachycardia, AV blocks, atrial fibrillation, ventricular fibrillation, or ventricular tachycardia. Most importantly, in patients of ST elevation MI, if they have a concomitant hypokalemia, then these patients will also have an increased risk of ventricular fibrillation. And the ECG manifestations, I think the specific things that we can look for in the ECG for the presence of hypokalemia ranges from something like depression of ST segment, decrease in amplitude of T wave, increase in amplitude of U wave, and then QT prolongation. The very fact that it can lead to QT prolongation also endangers the onset of arrhythmias in this patient. And this is what we should be monitoring on the ECG in the relevant patients. Usually, the ECG findings are well seen in the lateral leads, namely V4 to V6. So, if any findings are there, they will be well appreciated in these lateral leads, that is V4 to V6. Now, it is also very commonly seen that hypokalemia is seen along with hypomagnesemia, and both hypomagnesemia can lead to hypokalemia and vice versa. And it has treatment implications as well, because if you will not treat hypomagnesemia, then the potassium correction will also not occur, in spite of the fact that you will be giving more than enough potassium supplements to the patient. But with reference to the cardiac arrhythmias, it was important to know that the combination of hypokalemia and hypomagnesemia can lead to increased risk of Torsades de Pointes, and thus can lead to morbidity and mortality. So in this ECG, we're trying to show you the U waves. That is a prominent U wave after the T wave that you can see. Most prominently, it is seen in the lateral leads, that is V4 to V6. So this finding should prompt you to look for the potassium levels in a given patient. So kidney abnormalities are wide ranging from the impaired concentrating ability to increased ammonia production, increased bicarbonate reabsorption, altered sodium reabsorption, hypokalemic nephropathy, elevation in blood pressure, and decreased phosphate reabsorption. So if we will just revise our kidney physiology, the nephron physiology, we'll remember that the potassium, these electrolytes, usually either through the active pumps or by passive diffusion will move from one space to the other. And if potassium goes low, then it will influence the movement of the other electrolytes as well. And the active secretory like systems in the cells will also be secreting potassium and will be absorbing sodium or the other electrolytes in the appropriate places. And these can explain various of these electrolyte abnormalities. Hypokalemia and increased ammonia production, if you will remember, is an important aspect in patients of chronic liver disease. And in chronic liver diseases, this hepatic encephalopathy can occur because of hyperammonemic reasons or normal ammonia reasons. The one of the important reasons of hyperammonia hepatic encephalopathy is hypokalemia. And if you relate this from here, then because of hypokalemia, there is increased ammonia production, and that can lead a patient with chronic liver disease to like decompensate to have hepatic encephalopathy. And that is why correction of potassium becomes a prime responsibility of the physician to check so that and correct so that the patient doesn't slip into hepatic encephalopathy. And there are very few instances where we will treat mild hypokalemia aggressively. And this is one of that condition. That is, in chronic liver diseases with mild hypokalemia will also be treated aggressively so that they don't there is like the hepatic encephalopathy is not precipitated because of hypokalemia. So this slide, though it might seem a little complicated and a busy slide, but it essentially summarizes the causes of hypokalemia. And it is very important for us to go through this slide because having like recognized a patient of hypokalemia, it is important to treat them to correct the potassium deficit. And at the same time, it is important for us to identify the causes of hypokalemia so that the same may be rectified to give long-lasting like reprieve to the patient so that he doesn't slip into hypokalemia again. So if I have to take you through this slide, I will try to draw your attention to two aspects of hypokalemia. One is the increased losses that can happen either through the route of gastrointestinal system or through the kidneys, through the urinary losses or through the sweat losses. And at the other aspect is the increased entry into the cells, that is the transcellular shifts. So these two forms the main causes of the hypokalemia that we have to remember, and we have to run this list through in our minds to know that what can be the likely cause. Another less important cause is decreased potassium intake. Yes, you will ask me why decreased potassium intake is not that very important as a cause of hypokalemia. And the answer is that our body tries to conserve potassium if we are consuming less potassium in our diet. What do I mean by this is that if you are having decreased potassium intake, then the normal urinary excretion of potassium will be decreased, and more of potassium will be conserved so that the serum potassium levels are maintained. But having said that, such a patient in having a steady state of potassium metabolism wherein the potassium levels are maintained within the physiological range at the by decreasing the potassium excretion in the urine, if this particular patient yeah. So if this particular patient has a second cause of hypokalemia, then he can slip into having a severe form of hypokalemia. So having said that, if I have to summarize this, patients with decreased potassium intake usually do not have hypokalemia. However, if they have an additional cause of hypokalemia, then they can lead to a severe hypokalemia-like situation. So this means that even in the patients with decreased potassium intake, if they present with hypokalemia, then you will have to look for one of the causes amongst these tables. That is either the increased losses or increased entry into the cells. So let's begin with from the increased entry into the cells. So these transcellular shifts happens because of the increased activity of sodium potassium ATPase. And this can happen because by and large, the commonest cause may be because of increased beta adrenergic activity or because of increased availability of insulin. We know that insulin facilitates the entry of potassium into the skeletal muscles and the hepatic cells. And so once the potassium moves into these cells, and hence the plasma potassium levels will fall and the person can have hypokalemia. And so if a clinical setting, I have to draw your attention to a clinical setting where this will become important is maybe in conditions where we have to give insulin to uncontrolled diabetics. Maybe conditions like non-ketotic hyperglycemia, maybe conditions like diabetic ketoacidosis, where if they are treated with insulin, then the potassium levels fall because of these intracellular shifts. At the other extreme, are conditions like diabetic ketoacidosis, where a second mechanism also runs, which explains the hypokalemia. Now, because there are ketone bodies such as beta hydroxybutyrate, which are being excreted in the urine, that this beta hydroxybutyrate is an anion, and because of the increased anion load in the tubules, there will be increased secretion of potassium in the distal collecting tubules to sort of neutralize this electrical discrepancy. And hence, increased anion load in the collecting distal tubular structures system will lead to hypokalemia. So DKA will lead to hypokalemia because of two reasons. One is because of the increased beta hydroxybutyrate load in the distal collecting duct, and the other is because we are treating with insulin, and hence the potassium will move on into the intracellular spaces. Another important cause of increased entry into cells is the elevated beta adrenergic activity. That can happen either because of stress or administration of beta agonist. A very common setting where we see this is in the maybe in patients of chronic obstructive airway disease, in whom we give them, we put them on on steroids, maybe hydrocortisone, and then we are nebulizing them with beta 2 agonist drugs. So these drugs can then cause these transcellular shift of potassium because of the increased beta adrenergic activity. There are other important drugs such as theophylline, which like we don't use much nowadays. Theophylline can also cause a similar mechanism and can lead to hypokalemia. And in patients with theophylline toxicity, hypokalemia becomes a very important aspect and domain that needs to be taken care of and to treat because hypokalemia and theophylline toxicity, the combination thereof can also precipitate arrhythmias. Any stress for that matter, patient has fever, maybe post-surgical, any stress for that matter can also cause these transcellular shifts. Another important cause may be marked increase in blood cell production. So what do I mean? This is like maybe in patients admitted in hematological wards who are receiving GM-CSF. If they are given GM-CSF, that will induce blood cell production. And this increased blood cell production can lead to hypokalemia. A very other important cause in this setting, similar setting, clinical setting, is the administration of vitamin B12 and folate medications to patients with anemia. So when these patients are administered these hematinics, then because of the increased blood cell turnover, hypokalemia may occur, and that is why it is usually said that these patients should be monitored and their potassium levels should be monitored. An elevation in extracellular pH. So any problem, any pathology which leads to elevation in extracellular pH. So elevation of extracellular pH means that the hydrogen ion concentration decreases. And if the hydrogen ion concentration decreases, then the potassium will move out into the plasma to balance that electrical non-neutral situation. And that will lead to hypokalemia. Okay, so these are the causes. These are the important causes that can lead to hypokalemia because of the movement of increased entry into cells. And as we are discussing this, you can also visualize these clinical settings, and these are the histories that you would like to take in your patient who has hypokalemia to better understand that why your patient has hypokalemia. So at the other extreme, let me take you through the conditions which are due to the increased losses. And let us begin with the gastrointestinal losses. Vomiting and diarrhea are the two important causes which can lead to hypokalemia. However, these two conditions operate in a different physiological reasons because in vomiting, usually the acid-base disorder that is seen in vomiting is metabolic alkalosis. Whereas in diarrhea, the usual acid-base disturbance that is seen is hyperchloremic metabolic acidosis. So these two conditions, like when we do an analysis of acid-base disturbance, then whether your patient has metabolic alkalosis or metabolic acidosis will give you a direction of thinking what can be the underlying pathology. The laxative abuse or any tube drainage. So patients are on continuous Riles tube drainage or some intra-abdominal fluid drainage. So all these patients, because of the continuous potassium loss, can also lead to gastrointestinal losses. In this part, I will also like to draw your attention that the vomiting, that is the gastric secretions, has got very less potassium secretion. And if you look into the literature, then the maximal potassium loss in a patient who is vomiting is not through the vomitus or the upper GI secretions, but it is through the kidneys. Because of the compensatory mechanism, because when a patient is vomiting, he will lose chloride also. So to compensate chloride, bicarb will be absorbed in the kidneys, and the entire mechanism will then lead to increased potassium secretion. So that will also explain the formation of metabolic alkalosis in these patients. Now, another equal important cause of potassium loss is increased urinary losses. Very important cause is the person may be on diuretics. And amongst the loop diuretics and thiazides, it is more commonly seen in thiazides. The reason is that in furosemide also causes secretion of calcium into the urine. So when the calcium reaches the collecting duct, so it is not that anionic the milieu in the collecting duct is not that anionic, and hence lesser potassium will be secreted through the in the collecting duct. In the contrary, patients who are on thiazides, calcium is not secreted, and hence the milieu in the collecting duct will be more anionic, and hence more potassium will be secreted, meaning which that hypokalemia will be more severe in patients who are on thiazide diuretics. Now, many times what happens is the patient is on diuretic and they develop hypokalemia, but when they present to us, then these diuretics are stopped. So we need to take this consideration also when we are evaluating these patients, and we'll see that and we'll discuss it when we are discussing the treatment aspect. Now, at the other extreme are the chronic salt wasting, and the important causes of chronic salt wasting are basically primary mineralocorticoid excess and something like Bartter and Gittleman syndrome. So these are the chronic salt wasting nephropathies. And we know that Bartter and Gittleman syndrome are something like chronic diuretic use only, whereas where the pathology in the Bartter syndrome is similar to the use of furosemide, and Gittleman syndrome is similar to the use of thiazides. The other causes which can lead to urinary losses are renal tubular acidosis, hypomagnesemia, and drugs like amphotericin B, which will lead to tubular toxicity. Even polyuria itself can lead to increased urinary losses. Vomiting, we have already discussed that patients who are vomiting, the potassium loss is more due to the renal loss rather than because of the gastrointestinal losses. So loss is happening through the GI loss is also happening, but higher degree of loss is happening through the kidneys. DK also we discussed that DK can have hypokalemia because of two reasons. And so the same thing we are discussing here, proximal RTA, all of them because of the non-reabsorbable anions will lead to increased potassium secretion in the collecting duct. So having understood this, now we can move forward. Okay, I'll just skip this. Yeah, this is what I was trying to explain. That a steady state after initiation of thiazide diuretic is used after a few days. So what I mean to say by this is, let me take you through this graph. So in initial few days, when you're using thiazide, more and more of sodium and potassium will be excreted in the urine. But as the day progresses, this loss is then converted into an overall positive setting. So this means there is a steady loss, then gets converted into lesser and lesser of loss, and maybe the body tries to compensate and leads you to a place where there is lesser loss of potassium. And this may take about 3 weeks, and if not more than that. And the diuretic dose, if now, so having reached that steady state, if we increase the diuretic dose, then again they will start losing potassium. And or if the dietary potassium intake is reduced, or there are extrarenal potassium losses. So to simplify it further, what I mean to say here is that when you use diuretics, then in the initial few days the loss of potassium will be more, but after, let's say, about 3 weeks of the continuous use, that potassium loss becomes less, the serum potassium level stabilizes, and then the further fall decreases. And in these patients, if there is again a further loss, then think that either the diuretic dose has been increased, or there are extrarenal potassium losses, or that the dietary potassium intake is reduced. So this becomes important because when you're treating these patients, then how rapidly you have to treat, with what amount of potassium you have to treat, that all becomes very important, because treatment can also lead to rebound hyperkalemia. So these aspects are important for us to understand and tackle the situations. So with what history can they come to us? Well, they may be having history of vomiting, diarrhea, or they may be on diuretics because of various reasons, whether you're giving diuretics for hypertension control, or maybe because of certain cardiovascular reasons. And other than this history, you will also try to take histories which are relevant to the possible cause of hypokalemia, like maybe if they are diabetics, they have been admitted with DK, whether they are receiving insulin or not, and so on. Right. So all that history that we discussed in that slide in which we were discussing about the etiology, that will become important for you to understand what can be the underlying cause. Like when you're evaluating them clinically, then a very important aspect is that you will have to evaluate the muscle strength. Why so? Because you have to evaluate your patient for the severity of symptoms, and this understanding will then guide you that how aggressive your therapy should be. So someone who is having severe muscle weakness, this will translate into a severe potassium wasting, severe hypokalemia, and these patients should be on an aggressive treatment plan, in contrast to someone who doesn't have any muscle weakness, muscle strength, muscle weakness. Now, you will like to review their ECGs if they have any arrhythmias, in particular, whether they have a QT interval prolongation or not. Because if they have a QT interval prolongation, then somehow this becomes an emergent situation where you should take care of the hypokalemia in an emergent fashion, because we know that a prolonged QT interval in a relevant patients may lead to life-threatening arrhythmias. Now, what else you will try to evaluate? There are two aspects that you will like to evaluate in this patient. The first is the assessment of urinary potassium excretion, because by doing so, you will be distinguishing them like whether they have a renal loss, or they have an extrarenal loss, or maybe transcellular shifts. So again, this will become important because in patients who have transcellular shifts, they are notoriously vulnerable to have a rebound hyperkalemia if you correct their hypokalemia with the intravenous supplementations. So if they have severe manifestations, these patients with transcellular shifts, they'll be started on potassium, but they will be more meticulously, they should be followed up maybe every 2 hourly, 4 hourly for possible rebound hyperkalemia. Other than the assessment of urinary potassium excretion, you will have to assess the acid-base status. That is, whether they have metabolic alkalosis versus metabolic acidosis, because that will give you an understanding that where the likely root of loss is lying. And then that will also give you help you in planning effective management plan, and also to look for a possible cause. So the first and foremost thing was assessment of urinary potassium excretion. And how will you do? Well, we have two things that we can utilize here. One is the 24-hour urine collection, and the second is the spot urinary potassium and creatinine. Now, actually, 24-hour urine collection is said to be most accurate, and any loss more than 30 milliequivalent per day is inappropriate, meaning which that there is a loss that is happening through the renals, and you will look into the causes that lead to increased renal loss of potassium. However, this will become inappropriate in the setting of polyuria. And when why so? Because in the polyuria, the potassium that is like evaluated in the 24-hour urine collection will not be a definitive reflection of the actual potassium that is being excreted, and hence polyuria should always be ruled out before you contemplate evaluating the 24-hour urine collection. On the other side, the spot urinary potassium creatinine is not influenced by urine volume, and that is easier to do also. And any value which is more than 13 milliequivalent per gram creatinine or 1.5 milliequivalent per millimole is inappropriate, meaning which that this will imply that there is increased renal losses of potassium that is happening. So there are also certain conditions in which there will be a higher urine spot potassium creatinine ratio even in GI losses. So something like a laxative abuse or bulimia nervosa, which can lead to vomiting. So we just understood that in vomiting, the major chunk of potassium is being lost in the kidneys. So there is a possibility that when you do a potassium assessment in the urine and it is on a higher side, then it can be not only reasons of renal wasting, but it can also be because of the GI losses. And these are the sodium to chloride, urinary sodium to chloride ratios that will give you some insight that what is the likely etiology for the like the hypokalemia. So ranging from Gitelman-Barter to bulimia to laxative abuse, you will have to find out the ratio of urine sodium to chloride, and that will give us an idea that what is wrong where. So this will depend upon how much sodium and how much chloride is being lost in the urine. Now, another concept is evaluation of urinary transtubular potassium gradient, that is well known as TTKG, that is transtubular potassium gradient. So what happens is that in presence of low creatinine excretion, for example, people who are with low muscle mass, urinary potassium estimation may not be optimal. So in this group of patients, particularly in patients with low muscle mass, the urinary excretion of potassium may not be reflective of the true situation. And in these patients, maybe you would like to do a TTKG. And this is the formula by which you can evaluate the TTKG. That is the product of urine potassium, that is a product of urinary potassium with serum osmolality divided by product of serum potassium and urine osmolality. And any value less than 3 to 4 means that there is absence of renal potassium wasting. So if TTKG is calculated to be less than 3 to 4, then this means that wasting is not happening through the kidneys. So many people and many centers, they do a TTKG and spot urine potassium estimation both together to have a meaningful understanding of what is going wrong. Now, the second aspect of the evaluation of the acid of the potassium of hypokalemia was acid-base status, assessment of acid-base status. So when you are evaluating acid-base, then you need to measure the serum bicarbonate, albumin, chloride, urine pH, urine electrolytes, and the ABGA to have a holistic understanding of what is going wrong. So the likely scenarios that you will run into are first, metabolic acidosis with low urinary potassium losses, and this will happen with GI loss, namely laxative abuse and villus adenoma. Or at the other end, there might be metabolic acidosis with urinary potassium wasting that can happen in diabetic ketoacidosis and renal tubular acidosis. So means that when you look at metabolic acidosis, the loss can be either through the GI, in particular lower GI, and or through the urine potassium wasting, and the settings will be diabetic ketoacidosis or renal tubular acidosis. At the other extreme is the combinations of metabolic alkalosis. So the first possibility is metabolic alkalosis with absent urinary potassium wasting. This can happen with some patients of bulimia, not all, some patients of bulimia. Diuretic use after diuretic effect has worn out. And metabolic alkalosis with urinary potassium wasting with normal blood pressure, that can happen with diuretic use Gitelman syndrome or Bartter syndrome. Now, if you look into the urinary chloride concentration, this will be normal in Bartter or Gitelman, but low in vomiting, and might be low or high in diuretics depending upon in which state they are, meaning which that either they have presented with the efficacy of diuretic remaining or that the effect has worn out. Urine pH more than 7 reflects that the bicarbonaturia is persisting. And all of these investigations can help you to understand that where the problem will lie. The last possibility is metabolic alkalosis with urinary potassium wasting with hypertension, and the causes may be diuretic use because in a patient of hypertension, they are on diuretics, and the diuretic then can cause potassium wasting with metabolic alkalosis. The other possibility can be renovascular hypertension because of the renin-angiotensin system going wrong and the primary mineralocorticoid use. Another important aspect for you to evaluate is the assessing the response to potassium. So, like I would like to explain this in very simple terms is that when you start managing this patient and you give them potassium, so someone whose losses have been corrected, they have stopped and they are no longer losing potassium, these patients will respond very rapidly to the potassium correction. In comparison, if they don't show response to potassium, this means there are ongoing losses, whether that is a GI loss or that is a renal loss. And that will give you a direction to know that something like further evaluation of the patient is needed. Estimating the potassium deficit becomes important because then when you're planning the potassium supplementation, then how much potassium needs to be given, that can be calculated. And a rough idea is that in patients with acute fall in potassium, if the serum potassium falls by about 0.27 milliequivalent per liter, then there is about 100 milliequivalent of loss. On the contrary, in chronic conditions, if like a loss of about 200 to 400 milliequivalents of potassium will translate to a fall of serum potassium by about 1 milliequivalent per liter. So in chronic conditions, if there is a loss of potassium by about 1 milliequivalent, then a very high loss of about 200 to 400 milliequivalents of potassium can occur. And this will make you plan that how much potassium needs to be given to the patients. However, this will not work in DK or non-ketotic hypoglycemia or redistributive hypokalemia because of obvious reasons, because multiple reasons are causing hypokalemia in these patients, in patients with DK and non-ketotic hypoglycemia. And in redistributive hypokalemia, what happens is that as soon as you start treatment, the potassium will move back to its appropriate place, and hence like the true potassium deficit cannot be calculated by this concept. And as I said, this estimation is very important because you want to plan how much potassium you want to give, and also because you want to avoid rebound hypokalemia, because someone with redistributive hypokalemia, a very high chance of rebound hypokalemia can exist. So what are the goals of treatment? The first and the foremost will be managing emergencies, because the emergent situations with which they can present to us are the arrhythmias or even muscular weakness. They can come to us with quadriparesis, and even respiratory muscle may get involved. So all of them are potential emergencies. We have seen that how hypokalemia can also cause myoglobinuria. So these patients can also come to us with acute renal failure. That is also another emergency. So these emergencies should be tackled as a priority. Then comes treating the potassium deficit. So the patients who have an emergent presentation, in those patients, you will target to rapidly raise these levels to a certain amount, and then we will then slowly correct the remaining deficit over days to weeks. And finally, what you have to do is you have to identify the etiology and you have to work on that. So urgency of management will depend upon rapidity of onset and severity of hypokalemia that we have already spoken about in the initial slides. And close monitoring has also been stressed upon again and again, because the correction can lead to rebound hypokalemia. What are the types of potassium available to us? Mostly we use potassium chloride, whether that is in the oral or intravenous form. But it is recommended that like potassium bicarbonate may be used in conditions in which patients have associated metabolic acidosis, because then the bicarb can take care of the acidosis and potassium can correct the hypokalemia aspect. The dietary potassium in the form of fruits and all that, they have very low potassium, and also they are in the form of potassium bicarbonate or citrate, and they don't raise potassium to a very high levels in a brisk manner, and hence they are not advisable for treatment, but they remain as important dietary sources of potassium. Some important tips. Well, always don't forget to identify hypomagnesemia, because you can have a group who have hypomagnesemia and hypokalemia together. And if we target only the hypokalemia correction, then the potassium correction will not happen unless and until we correct the hypomagnesemia part. So this can also be inferred in a way that patients who are not responding to the usual treatment, then the possibility of hypomagnesemia should be suspected and the same should be treated. Rebound hypokalemia, well, that should always be looked after, and we have been stressing on this again and again. But patients who have these transcellular shifts, non-specific, matlab, recurrent transcellular shifts, something like a thyrotoxic periodic paralysis, you may like to consider non-specific beta blockers, because then that will cut down on the frequency of the presentations. Now, there can be one particular scenario wherein you are asked to manage an uncontrolled diabetic with hypokalemia. So in these setting, like we maybe like consider putting them on insulin before correction of potassium. This should never be done, because hypokalemia will fall further and that can precipitate arrhythmias. So in this condition, first priority should be correction of the potassium to at least to a level of about 3.3 milliequivalents per liter, and then only the insulin part should be insulin should be started to manage the diabetes part. In DKA, as we have discussed previously, that the potassium that is reflective in the serum potassium level, that may be because because of the increased potassium into the tubular structure, because of the increased anion burden in the collecting duct in the form of beta hydroxybutyrate. So if we give them insulin, then there can be further loss, and patients may fall into hypokalemia. So potassium and also to manage them better, the potassium replacements should be done only when the level of potassium is below 4.5. Because if you give them potassium at a higher level, then that will be detrimental. So in rhabdomyolysis patient, because of the muscle breakdown, there might be associated hypokalemia. Along with hypokalemia and the potassium, like the serum potassium may not be truly reflective of the actual situation. And in this, patients of rhabdomyolysis with a potassium on a higher range, you will never give potassium. But in patients who have hypokalemia, if you start replacing, then the potassium may be added because of the muscle breakdown also, and hence a rapid rebound hypokalemia can happen. So in patients of rhabdomyolysis with hypokalemia, these patients should be replaced with potassium in a cautious manner, and they should be monitored more frequently. It is also advised by some that 1/2 isotonic fluid should be used as a transport medium for potassium, because addition of potassium into normal saline will make it hypertonic, and hypertonic fluid can have its own sets of complications. And only normal saline should be utilized, not dextrose containing fluids, because dextrose containing fluids will lead to insulin secretion, and that insulin secretion can lead to intercellular shift of insulin, and hence the correction should be done only in the normal saline or mannitol, as it is advised in patients of periodic paralysis, and preferably in N/2 fluid. Now, identifying ongoing losses versus chronic losses is also equally important, because if they are having ongoing losses, then they will need higher quantity of the potassium that will be needed for correction, and that losses may be estimated, and the required amount of potassium may be instituted to the patient. In the contrary situation, we have patients with chronic losses, and I did show you a graph that how these patients tend to reach a steady state level, wherein the body tries to compensate the potassium losses, and then the potassium levels are brought back to maybe low normal or just mild hypokalemic levels. Now, if we try to treat them by giving potassium, so then what happens is, if you will give potassium, so the body will perceive that it is getting an extra load of potassium, and suddenly they will lead to more potassium losses. And after an initial rise in potassium, then they will have a subsequent rapid fall in potassium, and they will have more of hypokalemia. So what it is suggested here is that in this setting, patients with chronic losses, we can consider potassium sparing diuretic, something like an aldosterone that may be added, and that will lead to or a better outcomes. Patients with mild hypokalemia, that is between 3 to 3.5 milliequivalent per liter, are usually not treated, meaning which that they are not treated aggressively. They may be given oral potassium chloride, and you would like to work them up for what is the cause, and you would like to rectify that. However, in patients of mild hypokalemia with chronic liver disease. That is what we have stressed previously also. And in patients with mild hypokalemia, with patients who are on digoxin. These two category of patients, you will keep a careful watch on even mild hypokalemia levels of potassium, that is 3 to 3.5. And we will like to have an aggressive correction because CLD patients will be bound to slip into hepatic encephalopathy in this range. And patients who are on digoxin can have life-threatening arrhythmias. So, barring these two conditions, mild hypokalemia are treated just with oral potassium chloride, and we will like to just know the causative agent. At the other extreme is those patients with severe hypokalemia, that is 2.5 to 3 milliequivalents per liter, or irrespective of the level, they have severe clinical manifestations of hypokalemia. So these patients will be aggressively treated, probably both with oral and intravenous potassium correction with more frequent like potassium monitoring. What is the recommended rate of infusion? The recommended infusion rate of potassium administration is between 10 to milliequivalent per hour in most of the patients. But with those with life-threatening hypokalemia, the rate can be as high as 40 milliequivalent per hour. And but any rate which is more than 20 milliequivalent per hour is highly irritating to peripheral veins, and such high rates should be infused into a large central vein or into multiple peripheral veins. So we can we may need to put a central line in these patients who have life-threatening hypokalemia, and we intend to give them very high rates of infusion. So if we give very high rates of infusion, that can lead to phlebitis and pain, and even can risk them to have arrhythmias. Now, it is preferable that wherever available, we use infusion pumps, because by infusion pumps, we can tightly regulate the flow rates, and we can avoid a potential clinical condition wherein the more than required infusion rate happens by mistake, because that can have catastrophic implications. So I think with that, I will end here. And if I hope this was meaningful, and I could explain the important aspects of hypokalemia and its management. If there are any questions, so I will be happy to take them. I think. Uh, am I audible?